Now that we've covered bone scintigraphy and monoclonal protein testing, let's move to the next critical decision point in the diagnostic process: stratification and subtype classification. This is where all the earlier information comes together and where your clinical reasoning becomes key. So here's how we approach it. It's important to recognize that a biopsy is not a viable screening tool. Despite its high sensitivity, it doesn't tell us the extent of myocardial or systemic involvement. It also can't assess treatment response or progression, areas where modalities like cardiac MRI, PYP scintigraphy, and strain echocardiography have clear advantages. In short, biopsy is reserved for cases where imaging and laboratory results leave us in diagnostic uncertainty. So while biopsy still plays a role in cardiac amyloidosis, especially in AL suspicion or ambiguous imaging, today's diagnostic strategies prioritize non-invasive imaging first, reserving biopsy for when uncertainty remains. Now let's take a closer look at confirmatory tissue biopsy methods. Endomyocardial biopsy is considered the most definitive diagnostic method for cardiac amyloidosis. It has near 100% sensitivity when appropriate sampling is achieved. The myocardial tissue is typically collected from the right ventricular septum using fluoroscopic guidance. However, it requires invasive catheterization, carries procedural risk, and demands specialized pathological expertise, resources that aren't always readily available outside of tertiary care centers. That's why EMB is generally reserved for patients with unclear imaging results or those in whom AL amyloidosis must be ruled out. When the risk of cardiac biopsy is prohibitive, extracardiac tissues offer a less invasive route. Fat pad aspiration, labial salivary gland, or peripheral nerve biopsies may reveal systemic amyloid deposits. These sites are particularly useful when AL amyloidosis is suspected and systemic involvement is likely. While they're less sensitive for detecting cardiac amyloid, these biopsies are easier to perform and generally safer, especially in frail patients. A newer promising technique involves carpal tunnel biopsy, especially in patients with a history of bilateral carpal tunnel syndrome, a known red flag for ATTR-CM. Amyloid infiltration in the transverse carpal ligament can be sampled during carpal tunnel release surgery, offering both a therapeutic and diagnostic benefit. When a biopsy is obtained, immunohistochemistry can be used to identify the amyloid subtype. However, this method has shown inconsistency in many cases, especially when trying to distinguish AL from ATTR subtypes. That's why, regardless of the site, the biopsy process includes Congo red staining to confirm the presence of amyloid, followed by mass spectrometry-based proteomics, particularly laser capture tandem mass spectrometry, or LC/MS/MS, has emerged as the most accurate technique for amyloid typing. It can identify the specific amyloid precursor protein in formalin-fixed tissue, even in complex or dual pathology cases. This approach is especially critical in patients with monoclonal gammopathy, where nuclear imaging alone cannot reliably distinguish between AL and ATTR subtypes. But here's the shift. With the advent of modern non-invasive imaging, we've reached a point where many cases of ATTR cardiac amyloidosis can be confidently diagnosed without biopsy, provided the patient has grade 2 or 3 uptake on bone scintigraphy and no monoclonal protein. So when is a biopsy still warranted? There are 2 key scenarios. When bone scintigraphy shows equivocal findings, for example, grade 1 uptake, which doesn't clearly support or exclude amyloid involvement. When a monoclonal gammopathy is detected, in this case, you must exclude AL amyloidosis, which imaging alone cannot do. Even when clinical suspicion is high, say an older African American male with heart failure and concentric LV hypertrophy, you still need tissue confirmation if monoclonal proteins are present. Let's now explore endomyocardial biopsy, or EMB, widely regarded as the gold standard for diagnosing cardiac amyloidosis. This procedure involves retrieving tissue directly from the right ventricular septum, enabling detailed histopathological and proteomic analysis. The tissue sample obtained is stained with Congo red, a diagnostic dye that binds amyloid fibrils. Under normal light, the sample appears pink. But under polarized light, it shows the characteristic apple green birefringence, a definitive marker of amyloid deposition. This histologic technique confirms the presence of amyloid, but not the type. For precise classification, additional testing is needed. That's where immunohistochemistry, IHC, and laser microdissection followed by mass spectrometry, LMDMS, come in. With proper technique, EMB offers nearly 100% sensitivity and specificity for detecting cardiac involvement in ATTR-CM. Let's take a closer look at this histopathological comparison between cardiac amyloidosis and acute myocarditis, using hematoxylin and eosin staining. In panel A, we see myocardial tissue from a patient with cardiac amyloidosis. Note the expanded interstitial spaces surrounding the myocytes, marked by white arrows, which are consistent with interstitial edema. There's also a mild infiltration of immune cells, highlighted by yellow arrows, but it's relatively sparse. Now contrast that with panel B, which depicts a myocardial sample from a patient with acute myocarditis. Again, we observe edema around the muscle fibers indicated by white arrows. However, here we see a much denser inflammatory infiltrate. The yellow arrows identify prominent immune cell invasion, which is a hallmark of active myocarditis. Finally, in panel C, we see another case of myocarditis, this time with a more severe presentation. In addition to widespread edema and inflammatory cell infiltration, this section reveals an area of abscess formation, pointed out by red arrows. These findings reflect tissue necrosis and purulent inflammation, which are not typical of amyloidosis, but are sometimes seen in fulminant myocarditis. So, in summary, while both conditions may present with myocardial edema, amyloidosis is characterized by extracellular protein deposition with minimal inflammation, whereas myocarditis involves extensive immune cell infiltration and, in some cases, abscess formation. While endomyocardial biopsy remains the most definitive test for cardiac amyloidosis, extracardiac tissue biopsy offers a less invasive alternative, especially in patients with suspected systemic amyloidosis. Let's explore the most commonly used techniques. Fat pad biopsy, also known as FPEB, is a simple, outpatient procedure often used to detect systemic amyloid deposition. It has good sensitivity for AL amyloidosis, around 79%, but it performs poorly in ATTR cases. In fact, according to Garcia et al., 2018, its sensitivity drops to just 12% in cardiac ATTR. That means a negative fat pad biopsy does not rule out ATTR-CM. Even large biopsy samples, those exceeding 700 cubic millimeters, do not significantly improve yield for ATTR, particularly wild-type ATTR, which often lacks sufficient deposition in fat tissue. So while FPEB can rule in systemic amyloidosis, it should never delay cardiac-specific testing when ATTR-CM is suspected. Now, let's take a moment to examine this high-power view of fibra or deposed tissue, stained with Congo red and visualized under polarizing light microscopy. What you're seeing here is amyloid deposition within the walls of small blood vessels. The hallmark feature is the apple green birefringence, which is clearly visible under polarized light, indicated here by the white arrow. This classic staining pattern confirms the presence of amyloid fibrils. Congo red binds specifically to B-pleated sheet structures typical of amyloid proteins, and when viewed under polarized light, it produces this characteristic green hue. These findings are diagnostic and support the presence of amyloid angiopathy in the sampled fibrodeposed tissue. Identifying amyloid in blood vessel walls, especially with this birefringence, is a critical diagnostic clue in systemic amyloidosis, including both AL and ATTR subtypes. Next, let's look at a minor salivary gland biopsy. This is sometimes used in systemic amyloidosis workup. While less invasive than EMB, its diagnostic yield is generally lower, especially for ATTR. It may be considered in multisystem disease, but isn't a first-line approach for isolated cardiac involvement. Sural nerve biopsy, on the other hand, plays a critical role in the diagnosis of hereditary ATTR, especially when neuropathy is the presenting symptom. Although non-invasive techniques such as genetic testing, bone scintigraphy, and cardiac MRI have become standard, nerve biopsy remains indispensable in atypical cases, particularly when genetic or systemic results are inconclusive or when neurologic symptoms predominate. In a multi-center Italian study involving 69 patients, Congo red-positive amyloid deposits were detected in 72.5% of sural nerve biopsies. However, the positivity rate varied significantly with TTR mutation subtype. For example, 87.5% in Val30 MET versus only 48.2% in P64 LOI. Across all genotypes, moderate to severe axonal loss was observed in 94% of cases. Additional features included active axonal degeneration, regenerating clusters, and thin myelin sheaths, all consistent with the length-dependent neuropathy typical of hATTR. Nerve biopsy pathology findings: moderate to severe axonal loss, regenerating clusters, demyelination patterns, and Congo red and anti-TTR immunofluorescence. To summarize, extracardiac biopsies can help detect systemic amyloid, but they're generally less sensitive for detecting isolated cardiac ATTR. Fat pad and salivary gland biopsies may aid diagnosis in AL amyloidosis or multisystem disease, while sural nerve biopsy is more specific to hereditary ATTR with neuropathy. But when extracardiac findings are negative or inconclusive, we return to the most definitive tool, the endomyocardial biopsy. In this section, we'll explore an emerging but clinically valuable approach to identifying transthyretin amyloidosis early: carpal tunnel biopsy. Carpal tunnel syndrome isn't just an orthopedic concern. It can, in fact, be one of the earliest signs of a TTR amyloidosis, often preceding cardiac symptoms by several years or even decades. That means the tissue removed during routine carpal tunnel release surgery offers a valuable diagnostic opportunity. Studies have shown that tenosynovial and transverse carpal ligament tissues often harbor amyloid deposits, especially in older adults with bilateral symptoms. When stained with Congo red or theoflavin S and analyzed with mass spectrometry, these tissues can reveal both wild-type ATTR and hereditary ATTR. In fact, amyloid deposits have been found in up to 50% of patients undergoing carpal tunnel surgery, many of whom had no prior diagnosis of amyloidosis. That makes this biopsy a powerful tool for early detection and proactive management. One institution leading the way is the Cleveland Clinic, which developed a two-tiered screening algorithm. Tier 1 includes patients: males aged 50 or older, females aged 60 or older, or anyone with bilateral carpal tunnel syndrome. Tier 2 adds clinical comorbidities such as spinal stenosis, biceps tendon rupture, atrial fibrillation, pacemaker implantation, or even a family history of a TTR amyloidosis. Patients who meet two Tier 1 criteria, or one from each tier, qualify for Congo red staining of their surgical tissue. If amyloid is detected, mass spectrometry is then used to determine the exact protein type. So what does this mean for clinical care? When ATTR is identified through carpal tunnel biopsy, patients can be referred early for cardiac and systemic evaluation. This paves the way for timely intervention with disease-modifying therapies like tafamidis before irreversible cardiac damage occurs. In summary, carpal tunnel biopsy, especially when combined with structured screening protocols, provides a low-risk, high-yield method to uncover ATTR amyloidosis in its earliest stages. It's a strategy that bridges orthopedics and cardiology and reflects the importance of interdisciplinary collaboration in modern amyloid care. Now let's look at a real-world example with Dr. Mary.
Hello everyone, this case highlights how carpal tunnel release surgery can reveal hidden systemic disease. A 65-year-old woman with a background of hypertension and a previous myocardial infarction presented with classic symptoms of bilateral carpal tunnel syndrome: numbness, pain, and tingling that radiated into her fingers. Neurological evaluation confirmed positive TNL signs on both wrists and a positive Phelan's test. EMG and nerve conduction studies showed bilateral CTS with signs of active denervation. During left-sided carpal tunnel release surgery, the surgical team biopsied the flexor tenosynovium and the transverse carpal ligament. What they found was significant. Texas red staining of the tissue revealed amyloid deposition. To confirm the type of amyloid, they proceeded with liquid chromatography mass spectrometry. The results identified peptides consistent with hereditary transthyretin amyloidosis. Following this discovery, the patient was referred for cardiology evaluation. Further imaging and lab testing confirmed the presence of cardiac amyloidosis. This case emphasizes the diagnostic value of routine biopsy during CTS surgery, especially in patients with bilateral symptoms and additional cardiovascular risk factors. Thanks to this surgical biopsy, the patient was diagnosed with ATTR before significant cardiac deterioration occurred, opening the door for timely intervention. In this next case, we'll examine how a routine orthopedic procedure revealed an unsuspected diagnosis of wild-type transthyretin amyloidosis, commonly referred to as ATTR-CM. A 76-year-old male with a medical history of cervical stenosis and hypertension presented with bilateral numbness and pain in the median nerve distribution. On physical examination, TNL's and Phelan's signs were positive on the right, but negative on the left. Electromyography, EMG, and nerve conduction studies, NCS, confirmed bilateral carpal tunnel syndrome. During left-sided carpal tunnel release surgery, biopsies of the flexor tenosynovium and transverse carpal ligament, TCL, were taken. Histopathology using Congo red staining, without polarized light, revealed the presence of amyloid deposits. The specimen was further analyzed using light chromatography tandem mass spectrometry, confirming the diagnosis of wild-type transthyretin amyloidosis. Following the biopsy result, the patient was referred to cardiology. Subsequent imaging and laboratory tests confirmed a diagnosis of cardiac amyloidosis. This case illustrates how asymptomatic cardiac ATTR-WT can first present in peripheral tissues like the wrist, and how early biopsy during routine carpal tunnel surgery can serve as a crucial diagnostic gateway. As with hereditary forms, identifying wild-type ATTR early allows us to initiate timely cardiac evaluation and appropriate therapy before overt heart failure develops.
Thanks, Dr. Mary. Now, to wrap up this lesson, here are the key takeaways. 1. Carpal tunnel biopsy, especially of tenosynovial and ligament tissue, is a powerful tool for the early detection of transthyretin amyloidosis. 2. A positive biopsy result should always lead to cardiac evaluation, even in patients without symptoms. 3. Remember, ATTR-CM can remain silent for years before clinical heart failure appears. Early recognition is critical. 4. Starting tafamidis therapy in the early stages of the disease can significantly delay progression and improve outcomes. 5. And finally, if you encounter bilateral carpal tunnel syndrome, especially in older adults or those with other tier 2 inches red flags, think systemic amyloidosis. Together, these points emphasize the role of peripheral tissue pathology as an entry point into systemic diagnosis and the opportunity it presents for early, life-altering intervention. In the next lesson, we'll cover genetic testing for TTR mutations, an essential step in classifying ATTR and guiding treatment decisions.